Hi, welcome to another episode of Stein Fireside Podcast. We're here with Dr. Jeffrey Raskin, who is an associate professor of neurosurgery with Northwestern Pediatric Hospital and specializes in neuromodulation for pain in children.
That's right. I'm happy to be here. Thank you for inviting me.
Thank you.
Thanks for being here.
So you already know what Stein is because you've been coming to the meetings for years. You probably have a bunch of the
I got
Steins already.
two or three of them. Yeah.
Yeah. It's great to have you on the podcast. Well, I've known you for probably about 10 years, directly and indirectly, because we both do pediatrics, we both do functional. So it's finally wonderful to have you on the podcast. We take care of children all the time, but tell me about Jeffrey Raskin, the child.
A child. I have this picture here of me as a young, I think third grader. Always sort of interested in science. Born and raised in Las Vegas, Nevada. To two parents who eloped from New York to make it in Las Vegas, and then my little sister who's about 11 months younger than I am. And we grew up together very close in Las Vegas, and then I kind of moved along and graduated and went to Pomona College in Los Angeles, and then majored in neuroscience, studied abroad in London at University College London, where I met my wife Tia, and then came back home, and unfortunately didn't get into medical school, as that happens sometimes. Went to graduate school and got a master's degree, and then went to
What'd you get a master's degree in?
cell and neurobiology.
Okay.
Yeah, from USC, Keck
Cool.
School of Medicine.
Very nice.
And then got into my state medical school, went to OHSU, Oregon Health and Science University, neurosurgical residency, and then fellowship at Texas Children's Hospital, and then had a job in Indiana, and then
So at OHSU, was Kim Bircher your chair?
he was my chair for 6.5 years, and then Nate Selden took over my last half a year.
You take the average of those two and you wind up with you, actually.
Yeah, I mean, I think that's right. The functional experience at OHSU as a resident was incredible in pain and movement disorders. At the time, epilepsy was not quite so sophisticated. We didn't do stereo EEG, there were no lasers. That all came after I left. But fortunately, I matched in pediatric neurosurgery at Texas Children's, and there was plenty of that with Dan Curry and Howie Weiner. And so the education down there was phenomenal.
Yeah, and Selden is a scion in pediatric neurosurgery.
Right.
Yeah. Of course. That's wonderful. Did you plan on doing peds from the start
Of residency? No.
or before?
Never. I mean, I really kind of had no plan. I love neurosurgery. It's very exciting. Everybody sort of thinks a certain way about neurosurgery, and then it's really probably not that way. You can never fully be prepared for the pride-swallowing siege that it generally is, like every single day. But it was probably in my fourth or fifth year. It was my fourth year. So as chief of the pediatric service at OHSU, when I was there, you were really first exposed to pediatric patients and the advocacy of the parents and the children's hospital in general. And I did like the breadth of cases. Also loved the children. Very inspiring, stories about 2-year-old pulling a TV down on his head, and you think they're going to die, but they're just so resilient and perseverant. And just phenomenal stories. And so that's really why I kind of went into peds. It was the breadth of pathology. I thought very much I liked the way you could just kind of do everything. And then I also just really vibed with the families and the kids. So that either turns you off or kind of, brings you closer to the process.
Yeah. You play any sports growing up?
I played football.
Okay.
So I played soccer as a child, and then I went to a high school where they didn't have soccer, and they had football, and I transitioned to football. And then I played football there. I played football for 1 year in college, and then realized I had to buckle down. Probably didn't buckle down enough since I didn't get into med school. But it's hard to do both. But I played college football and AAA footballs for.
Okay.
It was fun.
And so you met Tia at UCL. UCL is Queen Square that's actually the birthplace of neurosurgery.
Right. Yeah. I mean, and I lived in a flat that used to be Charles Darwin's house, right across the street from the Darwin Anatomy building, which is just super cool. Went to the Wellcome Trust Library and read like original texts like Frankenstein, written in Mary Shelley, Percy's hand, and it was just an amazing place to go to school. But probably the best thing that happened is I met my wife Tia. Yeah. So I think I have a picture here. So Tia and I met in London, and we were supposed to get married but didn't, and then we both, were separated, married, and divorced other people, and then we found each other again. And that middle picture is Tia and I getting engaged in London as like 30-something-year-olds. I don't know, 35 maybe.
You went back to London and got engaged there?
We went back to exactly the same Garfunkel's that I met her at. Yeah.
What's Garfunkel's?
Garfunkel's is like the Olive Garden of London. Okay. It's like not a fancy restaurant. It's maybe the Applebee's. It's probably the Applebee's of London, right? So it's like very much not a fancy restaurant. It's utilitarian. But I had met her there when I was 20 and she was 20. And then so we went back there and we got engaged.
And then you were a pediatrics resident in Texas.
Yeah, fellow.
Sorry, fellow. Yeah. With I made a mistake with Dr. Curry. And I really think of him as I think of you actually because I do epilepsy, not pain. I think of you as an epilepsy surgeon first. But you must have had quite a bit of pain exposure there as a fellow, or?
It was mostly from OHSU, where I was a resident and learned a lot of the interesting sort of spinal cord stimulation techniques from Ahmed Raslan and some of the programming tricks, and really got interested in neuromodulation as a platform in general. That was my first exposure to RNS and pain procedures in general. A little bit of occipital nerve stimulation, but mostly spinal cord stimulation and pain pumps.
Okay. And there the pain was your exposure was mostly with adults?
It was all with adults, yeah. Oh, and also ablative therapies, which is uncommon. And then I also saw these functional fellows come through like every year working with Dr. Burchell and then Dr. Burchell and Dr. Raslan, and we would do cordotomies, right, in a much more frequent way than maybe it was being done around the nation. So the exposure to those sorts of ablative therapies for pain was impactful as a young, neurosurgeon to be what Dr. Burchell always called pond scum, like in a very loving way, I think. I don't know, 100% sure.
Yeah, he's classic.
Classic.
Yeah. He's the guy that brought DBS. A lot of people think he's the guy that brought DBS to America. Yeah. And he certainly, if he's not the guy, he's one of the guys. They run this great course there that you teach at, and I'm lucky to be able to go to as well. It's really a hub of functional neurosurgery in the country.
Yeah, it's a privilege to be invited to speak, and I mostly go to learn, and I bring other trainees along with me, different interests and stages of their career. But the real benefit of being there is being immersed for a few days with like your peers from around the world. We're really pushing the envelope and doing innovative things and like picking up things every time. I learn so much every time I go. So
yeah, I've certainly had. You go there to teach, but then you bring home lots of tricks.
Yeah, exactly right.
Yeah, absolutely. And then you started out in Indiana. How many years were you there for?
I was in Indiana for about 4.5 years.
Okay.
I really enjoyed it. It was a great place to start my career. Andrew Jay recruited me. He was very briefly my fellowship director at Texas Children's, then he moved on to Indiana. And he basically said, if you can sort of bring minimally invasive epilepsy from Dan Curry in his mind to Indiana, then I'll make a job for you here. And so that's what I did. And it was phenomenal. And I got to really build epilepsy surgery, but also movement disorder surgery and pain surgery there.
And then moving to Lurie Children's, that's one of the premier pediatric hospitals in the world and one of the premier pediatric neurosurgery centers in the world.
Yeah, well, I appreciate you saying that. I really think that's true. It was another fortuitous adventure for me because my chairs had changed, and then sometimes when chairs change, the vision changes, and you fit into that vision or you don't. And so it was an opportunity for me to grow. And I called Sandy Lamb, who's my boss and was one of my mentors at Texas Children's at the time when I was a fellow. And I was basically asking for help. I'm like, things aren't the way I thought they were going to be here, and things are changing. It might be time for me to leave. What do you think? And she said, well, we can sort of have you out here and see if this is a good fit for you.
Oh, really?
And so I interviewed there. I interviewed in the Bronx, and then it was like a great fit, and I loved it. And it was, I've never looked back. It's been really good to be there.
Because in Indiana, was that a dedicated pediatric hospital?
Yeah, so Riley Hospital for Children is a dedicated hospital, awesome hospital, really runs well. The people there are very diligent and dedicated to the care of children. And while I was there, it became a level 1 trauma center, and it was always a level 1 trauma center. It became a level 1 CSV accredited program, which is Children's Surgery Verification Program through the American College of Surgeons. So that was interesting to see that process happen. But it was always a very, very good hospital. I always had a 100% pediatric dedication unless I was operating on children or young adults who had pediatric conditions.
What's the process like for you guys at Northwestern when your children that you operate on and take care of over the course of years get to 18, 19 years old, looking to transition care?
Yeah.
Is it dependent upon what indication, or?
It depends upon a lot. I mean, I think that there's a warm embrace of the children's hospital that really parents and families are hesitant to unshrug, right? I mean, and it's not as soft and kid-gloved in the adult side as it is in the pediatric side, and I think that extends to all institutions. The transition program, I mean, fundamentally, we have an adult care policy at age 26. So at age 26, you really have to make an argument to the CMO of the hospital that this patient needs pediatric care. And you can make that more or less. But most of the patients at the age of like 18, 19, they're transitioning over to the adult side. It's easier for patients who have sort of a potentially operative condition, right? Like spina bifida, for example. Brain tumor. The brain tumor pathway is pretty straightforward for patients who have been monitored, who've had operations and so on, to go and continue being monitored in an appropriate way. What breaks down is really like hydrocephalus, like patients have shunts that haven't been operated in forever. We see them generally like every year or every 2 years. There's not very many guidelines on that. So it's just kind of like what's up to the institution and the practice. And then, the adult side is less like that, in a lot of cases, and they say you have a shunt, you haven't ever had a revision. The odds of us diagnosing it in a single random outpatient appointment is like 1%,
Yeah.
I mean, so they're like, we'll see you when you need it. And so then those patients kind of sometimes they're left to their own, devices, and they will get lost to follow up and stuff. So there's a lot of room for improvement there.
So it was at Northwestern that you sort of merged your pain experience with the peds practice? Or?
Yes. Yeah. I mean, I started doing pediatric pain surgeries at Riley when I was in Indiana, but it really started flourishing in Chicago. And I think that's because the interaction with the pain group and just maybe some iterative years and publications finally led to some acknowledgement. And I'm getting a lot of referrals from the institutional, so Lurie Children's Hospital Pediatric Pain Program. But I'm also getting self-referrals from families who just happen to Google, like, who can help me sort of thing.
Yeah, sure.
And so that's been really nice to see. And I try to make sure that the information out on the internet and in the form of patient education materials and dissemination of literature is accurate and honest. But I'm happy to see any patient who is referred to my clinic.
I think I see pain as a difficult thing to treat in children. Although I'm a functional neurosurgeon and I do pediatrics, mixed, but more pediatrics than adult. It's sort of a pain is a problem for adults. People think of the psychosocial component of it, but it's really in children, it's something that I feel like has not had the attention that it should. And the indications are a little bit different, right? I mean, you're treating a lot of children with cancer pain, children who may be at their end of their life. How do you find that psychologically different from epilepsy, where, we're treating something, and first of all, it's more objective to say when they're having issues related to seizures, you can detect seizures. We can measure them and then do something about them. Pain is real. There are biological mechanisms underlying it, but it's much more difficult. And the psychosocial components, I would think, would be different between children when you have a pediatric pain practice and adults in an adult practice. Can you tell us a little bit about that?
Yeah, I mean, I think that's right. Pain in children is a little bit harder to tease out as far as you're having chronic pain, but do you know what it truly is to have pain? There's developmental impact on the self-perception of what pain is. And there's also, various dimensions to pain that may not be as defined in pediatric mind. For example, the emotional and the cognitive component of pain. So physical pain, of course, we know children can feel, right? I mean, we can elicit it.
Right.
They stub their toe, they break their arms, they have the same physical manifestation of pain, but the extent to which their cognitive and emotional modifying factors to their pain is really hard to understand. It's hard to understand in adults, especially hard to understand in a 10, 11, 12-year-old who has trouble understanding their own place in the world and trying to go through the self-determination of puberty and stuff. So all these things sort of modify what their experience of the world is. And it's under-assessed. I think there's not as many validated tools in pediatrics as there are in adults. So generally are relegated to simple things like the visual analog scale, which is, not a great metric.
Yeah.
So we are in need of these like biomarkers, facial recognition, like other indicators of what a person's experience of pain is as a way to validate the inputs, right? So that the outputs can be sort of homogenized as well. Like what will the outcomes be for a certain homogenized group of inputs?
Yeah, I mean, I guess I deal with pain in children, but it's always post-operative. It's episodic in the sense that I expect it to, when you have a child who's either sustained an injury or undergone surgery, it could get worse for a day or two related to swelling, but then it's going to get better. But these chronic pain syndromes, obviously, that's not the case. And the idea of, I guess the idea of it being maybe we'll ask you a little bit about devices later, but the underlying sort of neurological changes that happen throughout development, growth, puberty can change your perception of pain in ways that are maybe more malleable than you have in an adult who has chronic pain syndrome of one kind or another, and you expect the way that they will look in 6 months to a year to be more or less like the way they look now, maybe with some more time and some more psychosocial changes related to their pain. Whereas for a kid, their body's changing size, the way they think about the world is changing, they have hormones. Have you seen a lot of, do you see a lot of differences in children who have chronic pain when you see them at 12 and then when you see them at 15?
Yeah, you do. You see a lot of differences because their pain is also being modified by their interaction and feedback from their lived experience, right? So some of the pain that the chronic pain that these patients manifest is an expression of their standing in the world. And so that can change with positive attention, right? Wins in their lives, like getting better grades and just being supported in general. And that can happen when you have continuous interactions with the medical sphere, especially in the form of like a surgical patient interaction with a device potentially, that they can call someone like the rep and say, I'm having a little bit of pain, and there's that emotional contact, right, and touch point. And that sort of, some people will criticize the device as not having an organic impact on their pain syndrome, but having more of a supportive emotional role. And I think maybe, it's hard to tease that out, but so what? I think also that is helpful for these patients. And so, you see an evolution in a person's pain syndrome. You see it in a positive way when they're sort of responding to these emotional touch points and the support of the medical industry in general, clinicians and non-clinicians alike. And you also see patients who have a psychological manifestation like depression or severe generalized anxiety syndromes. And those potentially get worse over time. So you see it both ways. It's rarely, I think, static. Like I just have 10 out of 10 pain all day, every day, and I just go to school and I come home. That's hard. It's a hard life to live if you actually do have 10 out of 10 pain.
That must be a real challenge, though, when you're, I guess, trying to kind of, I guess, change programs or change the surgical construct potentially over time when you're trying to, because you need some sense of causal relationship between what you're doing and the pain response.
Yeah.
How do you try to tease that out?
Yeah, I think that good constant touch points with a patient and developing that therapeutic relationship over time is really important. I also think it's absolutely critical to work with a comprehensive multidisciplinary group of specialists, like a pediatric pain program that can provide basically all the dimensions of pain support in the tiered fashion that we know, starting with all these different medicines of different modalities, excluding opiates and then including opiates if necessary, but also cognitive behavioral therapies and physical and occupational therapy and so on and so forth. Layering in all of these different adjunctive therapies, what we call first, second, and third tier therapies at the same time to help support a patient in the long term, I think is really critical and will help unmask psychiatric comorbidities that are absolutely antithetical to effective surgical strategies, like functional neurological deficit, which is very difficult to treat with a surgical therapy. Conversion disorder, very difficult to treat with a surgical therapy, right? And the experts who recognize those psychological comorbidities are the psychologists and the psychiatrists that are embedded within the pediatric pain programs.
What are the first, second, and third tier? Can you explain that to us?
Yeah. So first tier is sort of like medical management, but like Tylenol, over-the-counter medicines, Tylenol, Advil, sort of abortive strategies for nociceptive pain syndromes, right? And then, pain fundamentally is a symptom. It begins as a symptom, but it can then evolve into a chronic condition, a disease state, right? That has to be managed. And when we talk about chronic pain, that's what we're talking about. We're talking about a medical condition that needs to be managed, like high blood pressure. We're not talking about sort of initially when it's just a symptom of surgery, 1 or 2 days, and you're going to get better over time, right? So initially it's over-the-counter medicines, and then it evolves to sort of therapies and prescriptive medicines that are not only abortive, but preventative, right? And that might include tricyclic amines and so on that help. They have sort of a synergistic effect with mood disorder and also reducing pain through norepinephrine mechanisms and so on. And then it kind of goes on to include injections, Botox, analgesic injections, steroid injections. Mm-hmm. And then sort of fourth tier would be what is typically called neurosurgical procedures, but basically just pain procedures. It's not just neurosurgeons who do them, right? It's a lot of pain doctors who are appropriately and adequately trained to do a lot of these injections and implantations of electrode systems. Mm-hmm. It's like the ablative therapies of the central and peripheral nervous system that generally neurosurgeons need to do.
Yeah. Where do you draw a distinction between the right patient to get a destructive procedure, meaning you go in and you lesion part of the central peripheral nervous system, and an implant that's either a pump or a stimulator? Mm-hmm. Who's the right patient for one? Who's the right patient for the other?
Yeah, that's a great question. I mean, I think it's very nuanced. In particular, in the pediatric patient population, you have to take into account the changing relationship between the device and the growing human. Mm-hmm. And maybe it's okay to put in a spinal cord stimulator, for example, in an 11-year-old when you know they're going to get taller, and you will probably have to revise that lead as the spinal cord moves in relation to that, octrode electrode that you put in. And maybe that's okay, maybe it's not okay, Occipital nerve stimulators, I'm not aware of any that are MR conditional. Mm-hmm. And so if you put in an occipital nerve, you do a trial and then you do an implant in a patient, they have to know that they just can't get an MRI until the device is explanted. So these are things that you have to really consider in a pediatric patient compared to an adult patient, just because they have so many more years of life in them. And over time, like the majority of people are going to get an MRI at some point.
Yeah, of course.
I think when all things are equal, like for example, occipital neuralgia in a patient, even if it's a pediatric patient, you have two options. You have neuromodulation and then you have occipital neurectomy, right?
Yeah.
Or occipital nerve ganglionectomy. So those are the two strategies there. It's a neuromodulatory effect with electrical stimulation and electrical dosing, or it's in a resective destructive surgery. If you evaluate the evidence, especially in peds, you're going to find basically the same terrible level 3 data that suggests it's effective for some patients, right, in both cases. And so for me personally, I would err towards offering a neuromodulatory procedure, knowing that once you do a resection or injure the nerve or something, you can have permanent complications that are harder to treat, like neuroma, and then a ganglionectomy is not a small procedure. You have to go down into the spine, as you know, right, and find the ganglion and, resect them. And so I think that if you can get away with field stimulation using octrode electrodes, like that's a very straightforward soft tissue surgery. It takes 30 minutes.
And for those on the podcast, field stimulation is when you put a stimulator, and you could explain it, out into the tissue around the skull, as opposed to something where you're going in near the spinal cord and cutting those nerves as they come out. I think a problem that you and I both run into for children who have epilepsy is that a lot of the devices that we use in children are developed for adults, and we run into problems when we very rightly want to provide this therapy for children. But frankly, the barrier for companies to get approval for children is so high that they don't pursue it. And getting the kind of data that leads to simple FDA approval is a barrier that's very high. And so we have payers that we interact with who say, this is experimental, it's unproven, but of course the reason why it's not even experimental, and we know it works with these patients, it works with adults, the same strategy works with children. We run into these issues where it's very clear it's going to help these patients. We are not going to be able to have a large enough study to get simple FDA approval. I imagine that the problem, and so we wind up making arguments that rely on aggregates of data where it's small packages that maybe all get put together. And we have some ability to do this more in epilepsy because there's the ability to get more objective data. Whereas in pain, I think people are far too dismissive of pain to begin with. And in children, I think people can question the judgment of children to be able to assess their own pain. How do you have these kinds of arguments when you're really trying to get these therapies that people need, and yet you're potentially dealing with an entity where their main goal is just to not pay for something?
Yeah.
Yeah.
Yeah. Well, I think when it comes to neuromodulation for pain, even in the adult setting, payers are becoming less likely to approve and then subsequently reimburse. So overall, the field that used to be growing at about 6% per year is now growing at only about 2% per year. So overall, in the general context of what payers are thinking about spinal cord stim and peripheral nerve stim, they're less exuberant about reimbursing, let alone the fact that you're right, in pediatric patients, there are many limitations, ethical limitations, physical limitations as far as putting adult-sized devices in pediatric patients, developmental considerations, and so on. And all of those prevent us from developing any high-quality evidence. But the presupposition, I think, is that the pediatric patients, and we're not talking about little kids, we're talking about school-age children and adolescents. School-age children and adolescents have a very high rate of chronic pain and high-impact chronic pain where they can't go to school anymore and so on. And so I think really one benefit would be not only to produce like high-quality case series and so on as much as we can, but the development of registry data where we have a minimal data set that we would be able to present for pediatric patients. This is the diagnosis, this is the age, of course, the developmental ability, the device that's implanted, the programming, all of the things that go into an effective surgical strategy. need to be reported in a single bundle. And then the final thing is to consolidate all of that information in the form of something like a guideline. Now it's hard to make a guideline on level 3 or less data,
Yeah, sure.
but at least you can put out a position statement by like a respected society or group of societies.
Yeah, I mean, we've talked about this idea that for pediatric neuromodulation, having a group of people who get together and can reinforce by reviewing, and we may not reinforce, but by reviewing each other's cases and helping to provide support, at least when it comes to a consensus opinion that it's the correct thing to do for this particular individual. When I think of pediatric pain, you're the first person that I think of. I'm trying to think of who else has the same kind of program that they've set up like you have.
Chima Oluigbo does a fair amount of pain surgery, and when the ASPN, the American Society of Pediatric Neurosurgeons, had a little pain debate, it was Chima and I on the stage talking about it.
Yeah.
And then Virendra Desai has a number of papers. The most recent one, I think, was resecting the occipital nerves, the greater occipital nerves for occipital neuralgiform headaches. So
Yeah.
that's who I would say.
Have you found any pain syndromes that are unique to children?
Very interesting. I have. And so the thing is, pediatric patients are first experiencing pain from their embryo dysmorphic conditions. So spina bifida, duplicated pelvic conditions, spinal cord tethering, and then the subsequent resections, plural, that might come to treat that. And so it's an interesting phenomenology because it's a mixed pain disorder, including neuropathic and nociceptive phenotypes. And the interplay between like their young development and understanding of how to describe those pain syndromes and then what helps to treat those pain syndromes is very interesting. I did find that spinal cord stimulation is great for urogenital dysfunction in response to recurrent tethered cord surgery. It's probably a consequence of sort of like arachnoiditis ossificans or just arachnoiditis in general. So those are certain conditions. And then pediatric patients, of course, they're first experiencing things like hematopoietic crisis in the setting of sickle cell, right? And where they have like multiple infarcts of their long bones and pain. And a lot of these pediatric patients are treated a lot differently than some of their adult counterparts who have pain pumps implanted, right? Or are at least hospitalized for a length of time to treat their chronic pain, whereas children are sort of more commonly blown off or treated less.
Now, when it comes to giving children medications for pain, I imagine that is different in the sense that usually they have somebody supervising them, for lack of a better way of putting it, whereas a lot of adult patients who have pain syndromes are supervising themselves. Do you feel like the propensity for developing dependency is less in the PEDS patients that you see who are considered for surgery, where they may require pain medications, but I don't want to say abuse component, because adults who have pain syndromes and are on high levels of opioids, there's always going to be a propensity for abuse, but the medication itself is helping their condition. Whereas for children, there's a parent, there's somebody looking out for them. Does that simplify the psychosocial component when it comes to medications and then trying to assess how to come off the medications after they've had a device implanted and maybe getting some benefit from the device?
Yeah. I mean, it's a hard question for me to answer because I wouldn't be the primary person weaning those opiates and so on. I mean, I would definitely rely on my collaborating physicians and clinicians, the APPs and so on in that pain group. I'll say that it's very common for patients who were on myriad medications, including opiates for whatever, CRPS, right, of the leg, after a spinal cord stimulator, to see them again 6 months later off of all medicines is pretty common.
Okay.
And if not off of all meds, significantly reduced on medications. And I think there's a component to everybody, all chronic pain patients, that is somewhat predictive of your response, at least to surgery, which is motivation. How motivated are you to get back to your old life? Like, If we could take away all your pain, would you go back to work, right? And that's been shown in the DoD literature with officers versus non-officers, and officers having a much higher rate of return to service than non-officers, sort of quantifying this idea of motivation. And so I think that's something that I look for in a patient when I'm seeing them in clinic and I'm considering, are you going to be a good trial patient or not? One thing I really ask them is like, what do you want? And if they say, I want to get back to school, I want to graduate, I want to get a job.
So these are mostly your 15 to 18-year-old range, much more than,
much more than the younger kids. The younger kids are like, it's harder to figure out what motivates them. Like, are they truly motivated to get back to school? You know, but in the older adolescent population, you can sort of gauge it. And if they're motivated, I think they usually have a great trial and go on to a successful implant.
And your kids with cancer pain, are they mostly getting ablations?
Either ablations, although I have to say ablation is pretty hard sell. It's hard sell. I mean, even though it shouldn't be. There's plenty of evidence in adults, especially in the setting of cordotomy. It's like, sympathectomy and then cordotomy are the number 1 and 2 ablative strategies for pain in adults. And in children, it's really, one-off case reports and very small case series, but it does exist. Unfortunately, those are in patients where they die the next day, right? And it's sort of like a feasibility study or report, not an efficacy study.
Yeah.
And we know that in adults, it's extremely efficacious to reduce the opiate burden, the MME components, and promote wakefulness and awareness at the end of life, and lasts about 6 months.
Yeah.
But getting that message to the palliative care doctors and the oncologists who control that, patient referral basis has been a little bit tricky. So I haven't personally done those since residency, but I think it's a very straightforward procedure for a neurosurgeon to do. Very safe with modern sort of CT-guided cordotomy experience, right? Very safe. And then pain pumps generally is the most common procedure for patients with widespread cancer pain.
What does a multidisciplinary pediatric pain team look like?
Yeah, I think they should be described phenotypically because they might have different fundamental personnel, right? But they have a person, usually an anesthesiologist, could be a physiatrist or a neurologist, who has a good comprehensive understanding of what the pain management landscape looks like. Maybe they did pain fellowships. In some cases, they've just been around a long time, and they're good at injections. Maybe they're a radiologist who's good at, injections and stuff. But there's a good understanding of this tiered system that I've been describing. It's 1, 2, 3, 4, right? And then there are interventionalists. So there are medical doctors and nurses, nurse practitioners, very important. And then interventionalists like people who are capable of doing injections. Some of these injections are very complicated. Sphenopalatine ganglion injections is a complicated injections. If you don't know how to do it, you probably shouldn't be. So that is a contributor to a very sophisticated program. I think you do need pain doctors and/or surgeons, like neurosurgeons, who are capable of implanting devices even in the most complex surgical anatomy, like after fusions, with patients with multiple different resections because of cancer and so on. Trying to find soft tissue coverage for these devices is sometimes technically challenging. So I think that interventionalists, medical doctors and nurses, and then also psych people, so psychologists, psychiatrists, neuropsychologists, some sort of, professional at evaluating cognitive and mood disorders. This constitutes sort of a sophisticated, well-rounded program. You can add in a bunch of other stuff, like social work would be amazing, right? If we could have a social worker in every pain program. But I think that is mostly additive and not necessarily fundamentally required.
How do you see the, I guess, peripheral stimulation versus spinal stimulation? Obviously, it's going to depend on indication a little, but fundamentally, are they doing different things at a network level, or do you think we're just attacking the same circuit at just different points?
Yeah, I mean, I think the neural correlate for pain is immediately widely duplicative and distributed throughout the spinal cord. We talk about the anterolateral system and the medial system, but it's probably way more complicated than that, right? I think fundamentally peripheral nerves are mixed. I mean, almost all of them, right? And so you're really also not usually doing peripheral nerve stimulation unless you have wrapped a peripheral nerve, right? Which is very uncommon. You put the electrode next to the nerve or on top of the nerve or something, which is mostly field stimulation. So all that notwithstanding, I think that, the surgical dogma is very much so that in the setting of a like focal dermatomal or myotomal pain syndrome, peripheral to central stimulation is probably the way to go. But those head-to-head comparisons between peripheral nerve stimulation and spinal cord stimulation, I mean, are pretty infrequent. One example, though, is the pivotal trial for dorsal root ganglion stimulation compared to spinal cord stimulation. And that showed dorsal root ganglion stimulation in CRPS much more effective than spinal cord stimulation. And that's like I think they are stimulating at different areas. Those two platforms are totally separate platforms with different stimulation parameters and amplitudes. But nonetheless, it's very interesting to think of as a head-to-head sort of study. Spinal cord stimulation is more broad in its ability to get trunk, torso, legs down, right? But what it doesn't do great is get foot. It's really hard to get the fibers that go to the foot in the S1 dermatome. So in those kinds of patients, you might consider DRG stim instead.
We've been talking about spinal cord stimulation, peripheral stimulation. You do a lot of brain stimulation, just like I do. Have you ever done cranial stimulation for pain in a child?
No, I've never. I've done trigeminal neuralgia, MVD, microvascular decompression, in a handful of patients. I've never done stimulation, although I know Dan Curry and Nisha Gadgil at Texas Children's did a VPM stimulation for significant facial pain syndrome, and I think they reported that was effective.
Do you ever do cingulotomies, anything like that?
I would love to do cingulotomies. I think that, the putative mechanisms of pain, right, which is like transduction, transmission, neuromodulation, and perception.
Yes.
Perception is like the most fascinating part of pain, right? Because you can take two people with like the same
experience,
presumptive like primary pain generators, like an MRI scan that looks like degenerative disc disease like throughout the whole thing, and then one has like significant severe pain that limits their ability, and one is like totally fine playing golf every day. It's just fascinating, right? So altering the perception of pain, especially in the end of life, I think is something that really deserves a lot more attention. It's an ethical conundrum, right, to offer, especially to children, the opportunity to sort of disconnect emotionally from their pain through anterior cingulate gyrus surgery, either DBS in patients who might live a long time, or cingulotomy, anterior cingulotomy in patients who aren't going to live a long time. But I think that, we're starting to have these conversations a bit more frequently about pediatric pain and the management of their perception of their pain.
I mean, I think that's fascinating. I also think that as we have more and more capacity to do closed loop stimulation and also stimulation with nuanced spatiotemporal patterns, I wonder if pain surgery will involve essentially modifying the two at the same time. So spinal cord stimulator and a brain stimulator that both record and also interact with one another to deliver more complicated therapies. I think that'd be really interesting if that comes about.
Absolutely. We definitely need a much more sophisticated understanding of pain. And like any biomarker at all would be great. Of course, there's like Neurosense, which is ECAPS, sort of understanding of where the spinal cord is in space, but not necessarily a response.
That's really more, about just calibrating the amount of current to reach the spinal cord, right? So it's sort of a little different approach to closed loop than what we're thinking of as having a biomarker of the condition.
Absolutely. Yeah, but this idea of pain being like a subcortical nucleus stimulation and you're going to cure it, I mean, has been debunked by all 6 of the clinical trials for DBS for pain, right? So it's just not a thing. I mean, we're going to need a network understanding or some sort of much more granular understanding.
I mean, I've thought that we know, we do know how to play with reinforcement, but usually that's something we try to avoid, right? If you get anteroventral STN, you get people going gambling binges, you have a variety of different reinforcement, and we can also stimulate accumbens, although there I think it's a little bit more complicated of a story. But you might imagine changing the experience of pain with spinal cord stimulation, and in tandem with that, playing with reinforcement at the same time. And that's the kind of thing that I think you are doing brain stimulation not to modulate the experience of pain that's happening, is waxing and waning on ways where you don't have a good biomarker, but you're basically just introducing a proxy in the form of stimulation of the spinal cord and then reinforcing that at the same time. I think that's, I think we have the tech for that, but we don't have the understanding for that.
Yeah. Oh, that's very interesting. I wonder who's working on that.
I don't know.
Yeah.
Maybe you?
Maybe me. We'll see.
Yeah. Be a fun kind of thing to talk more about.
Yeah.
Yeah. You do some movement disorders in children. You do epilepsy in children. What experience with the devices that you have there are you able to bring over into pain?
Oh, that's interesting. So rhizotomy is a surgery that we do. It has a storied history for selective dorsal rhizotomy. Level 1 evidence that it plus physical therapy for diplegic spastic kids makes them walk better with less tone than physical therapy alone. So a very effective surgical strategy for decreasing tone through cutting the dorsal rootlets, which of course are the sensory rootlets, right?
Yeah.
And then applying that to pediatric patients who are non-ambulatory using a variety of different techniques like radiofrequency ablation, rhizotomy of the mixed nerve root, ventral and dorsal, or open ventral dorsal resection of the nerve roots. That comes from the pediatric movement disorder world, treating those two demographics of patients that I just talked about, the ambulatory diplegic patients and then the non-ambulatory GMFCS 4s and 5s who have very limited, autonomy, ability to perform activities of daily living. But those techniques can be applied to pain as well in the form of rhizotomy. And it's just less commonly done. But in the setting of dystonia, decreasing those nociceptive inputs really helps with the tone in sort of an outsized way than just taking care of the tone itself. So decreasing the sensory inputs is better than just not decreasing the sensory inputs and cutting the ventral root alone and taking care of the motor tone alone, if that makes sense. You asked about stimulators or devices.
Yeah.
So, they're in the movement disorder world, we have DBS really for primary dystonia. And to use that, we already sort of discussed how ineffective that is for pain syndromes, DBS alone for pain syndromes. So there's not a whole lot of application of devices for movement disorders to the pain world, but the ablative therapies can be sort of directly taken from movement disorder surgery to pain surgery pretty effectively.
Yeah. You'd had a photograph that you wanted to show us.
Oh, did I?
Yeah. I wanted to talk about this. You and I were talking about this earlier today, and this has more to do with, I guess, the experience of being a pediatric neurosurgeon and this idea that I think we both struggle with the anxiety and fear of hurting a child while trying to help them, and the shame that comes with less than optimal outcomes.
Yeah.
And we were talking about when you deal with trauma, sometimes it makes the job of being a neurosurgeon easier because the world hurt them, and you're doing your best, to help them recover from that. And I think that's why you said you brought this up.
Yeah, absolutely. I mean, that's absolutely right. Like the first thing anyone ever asks us is like, how do you handle the bad outcomes? Like, how do you handle as a little kid, a little tiny head? And it's like, when it's elective and you've convinced them to trust you, it freaks you out, man. It's how could you not be freaked out? And if things go wrong, like that can be really off-putting and can affect you kind of emotionally pretty significantly.
Very significant.
Very significantly.
Yeah.
It sometimes ends people's careers, to have a single bad outcome.
Yeah. Yes, I understand. I had a difficult outcome, and I was talking to a colleague of ours. I won't bring his name up, and I said, he's further on in years, and I said, how do you deal with this? And he said, the more time goes on, the more I think people tolerate a certain number of them, and then they retire. And that's hard to deal with. I mean, it's carrying a load. But I do feel like some of the trauma patients you it's a win.
No, absolutely.
It's an absolute win.
Because you're a total hero, right? It's like, I didn't do this at all. I was minding my own business. I was at a barbecue and you got kicked in the horse by kicked in the head by a horse, right? And now I'm here and I'm here to help. And so those can be kind of fun because the surgical complexity is often interesting. Yeah. And also like the patients generally do pretty well sometimes.
Yeah, they do. Yeah. It's difficult though, I'll tell you. I don't know what the way around it is. I do know that having friends who you can talk to, that helps you get through it, and people that go through the same experiences.
Yeah.
So glad to have you, and I'm glad to have my other friends in pediatric neurosurgery and
we're
my
all
friends in neurology.
Yeah, we're all glad to have you.
We're there with me. I've had cases actually with, I had a patient I was very, very, very fond of. A lot of my patients I'm very fond of. And I was operating on her and doing a DBS surgery for a child with dystonia. And, before every case, we go through in triplicate, make sure that there are no vessels that you can see on the post-contrast MRI or the CT venogram. You fuse them together, you look at both. And then I had blood coming out of the cannula when I was doing DBS. We did our microelectrode recording. For dystonia, we had normal track. And I pulled the microelectrode up and there was some bleeding there. And irrigated, with a microtip, it irrigated clear pretty quickly. I put a lead down, hoping that if there was some bleeding down deep, it might help tamponade it. Expediently got everything closed temporarily, brought the child to the CT scanner, everything was clean. And the girl has done wonderfully, thankfully. But, it took a lot to sort of get through and focus on the case without the anxiety of, this is a child that, maybe I really hurt. And I can tell you, I have him in the cases with me.
Yeah.
And sometimes having a friend, I just said, can you just stay till the end of the case? Because usually when we're done recording and we've confirmed the leads are in the appropriate spot, he goes and works on other things. He'd see him later in the day. So he hung out with me in the operating room. The case went wonderfully. The girl did wonderfully. But I'll tell you, sometimes in this business, having friends is so important. Yeah. And people that know that you care and then can sort of support you and vice versa. So.
Yeah, I think that's a shared experience. It's good to sort of normalize that because it's a really serious job, and we don't all have a emotional support neurologist, and we all should have an emotional support neurologist. No, I think that we're all in this together. It's good to sort of talk about that. Yeah, but traumas are freebies.
Yeah, traumas are freebies. And I feel like in pediatric neurosurgery, it's a great group of people where it's hard to have a big ego when you're dealing with little people. Yeah. You know what I mean? Yeah. So I think that all of us sort of are doing our best and on the same page about that. And we, people tend to put their own pride and everything else aside and just, try to make it work the best they can for these kids.
Yeah, there's certainly egos, but less. So my colleague, Mike DeCyper, always says, if you put a feather in your cap, neurosurgery takes 2 out of your ass. That's a good one. It's very true.
It's a humbling life, and I'm trying to take more joy out of really noticing when things go right and feeling good about that. Yeah. I think you had one last slide too, if I remember. Just if you could tell us about this. What is it that you geek out about? Was that this one?
Yeah, I think people you always ask why do you do what gets you up and out of bed and why you come to work. It's got to be a single driving mission. For me, it's legacy and it's improving pediatric neurosurgery in a broad sense for what patients can experience and can be treated for. So if you, Brian, you guys really are advancing, the field in a very specific way, and it's amazing. It's going to help a ton of people. But I think that for me, creating programs and defining referring algorithms and working on the advocacy piece and the patient and provider education materials and stuff, that I think is what gets me out of bed. And these pictures are a couple experiences there. One is on the left is the development of the laser program at Riley Hospital for Children when I was there. It went from 0 cases to 30 a year, which is the 4th largest in the nation for pediatric ablation before I left there. And then the one on the right is integration of a lot of different technologies to perform the first ever peripheral radiofrequency ablation rhizotomy for a patient with movement disorder that can be treated in a different way. So
That's great.
that's what gets me out of bed,
As it should.
keeps me coming to work.
That's something that's work to be proud of. I've really enjoyed having you on the podcast. Anything you want to add, or any parting words for our audience?
Oh, I think this has been great. I really appreciate it. Thanks for having me on.
Thank you so much for coming to the world headquarters of Stein. It's a pleasure to have you here. Thank you for joining our podcast. Hope to see everybody soon.